Chapter 14 deals with physical, cognitive, and mental health concerns as it relates to later life. Now, the chapter begins with a description of older adults in general and explores the diversity that exists among this group. If you didn't already realize this, not all older adults are alike. There are gender, racial, and ethnic differences, as well as differences in their socioeconomic status. Not only are there differences found among older adults, but research has even shown that they are living longer. The chapter also reviews lifestyle and biological factors that influence one's life expectancy, as well as ethnic, gender, and international differences related to longevity. Now, many of the descriptions and explanations of development used earlier in the textbook can be applied here. So we'll start, at least as we begin this chapter, with asking a very simple question. What are older adults like? People who study population trends are called demographers, and they used graphic techniques called population pyramids to illustrate these changes amongst the population. Now, a number of older adults is growing rapidly, especially the number of people over the age of 85. In fact, a number of such people will increase nearly 500% between the years 2000 and 2050 when compared to about a 50% increase in the number between the ages of 20 to 29-year-olds during the same time period. Individuals over the age of 85 generally need more assistance with daily living than do people under the age of 85. Older women tend to outnumber older men in all ethnic groups, especially in the United States. Projections for the future diversity of the U.S. population indicates very large increases in the number of Asian, Latino, and Native American older adults relative to European and African American older adults. In the future, older adults will be better educated than they are now. By the year 2030, it's estimated that about 85% of people over the age of 65 will have high school diplomas, and over 75% will even have college degrees. Internationally, the number of older students is also growing rapidly. China actually will have over 300 million people over the age of 60 by the year 2040. Challenges related to that include providing services and living arrangements for the aging population. The population of many countries will include substantially more older adults over the next few decades. Competing demands with children and younger and middle-aged adults for limited resources will also become a factor. Did you know that the number of years a person can expect to live is referred to as longevity? The average longevity or life expectancy is the age at which half of the people born in a particular year will have died. Now, the average life has increased dramatically this century, mainly due to the improvements in healthcare. Maximum longevity or maximum life expectancy is the longest time in any individual as it relates to the species in general. Researchers are differentiating between active life expectancy, which means living to a healthy old age, and dependent life expectancy, which is the length of time that one lives with a debilitating condition in which the person depends on others for care. Genetic factors that can influence longevity include family longevity as well as family history and the occurrence of certain diseases. Environmental factors that can also influence longevity include acquired diseases, toxins, pollutants, poverty, and even the life cycle. How environmental factors influence average life expectancy also changes over time. You see, people are responsible for the most environmental factors. Now, the impact of social class on longevity results from the reduced access to goods and services, which includes especially medical care. Ethnic group differences are complex. Depending on how old people are, different patterns of life expectancy emerge. For example, African Americans' average life expectancy at birth is roughly 6 years lower for men and 4 years lower for women than that of European Americans. By age 65, the average life expectancy for African Americans is only about 2 years less for men and about 1 year less for women than it is for European Americans. By age 85, African Americans tend to live longer. Latinos have higher average life expectancies than European Americans and African Americans at all ages. Interestingly, women have a longer average life expectancy at birth, which is about 5 years, than most men. There are even international differences in longevity. The current range extends from less than 40 years in Sierra Leone in Africa to over 82 years in Japan. The wide divergence of life expectancy reflects vast discrepancies in genetic, sociocultural, and economic conditions, healthcare, disease, and other related issues. What's referred to as the third age refers to the new view that old age is a time of potential growth rather than decline. It's characterized as the good news about aging. There's an increased life expectancy. There's a substantial potential for physical and mental fitness, along with evidence of cognitive and emotional reserves. There's also higher levels of emotional and personal well-being. Effective strategies are available that help master the gains and losses of later life. Now, the fourth age refers to the oldest old who are at the limits of their functional capacity. It's characterized as, of course, bad news. A majority focus is the choice of housing. Some folks choose a particular age and place, and others move to alternative placements. Sizable losses in cognitive potential and the ability to learn also factors the oldest of the old. There's increases in negative effects of chronic stress, higher prevalences of dementia, frailty, and multiple chronic conditions, along with problems with quality of life and dying with dignity as it relates to the oldest of the old. As you might well imagine, of course, there are a number of physical changes that influence health as people continue to age. There are actually 3 main biological theories of aging. Now, the first of those are metabolic theories that focus on changes in cell metabolism. Cellular theories focus on causes of aging at the cellular level. There are limits to the number of cell divisions involved, and telomeres play a major role in aging by typically shortening with each cell replication. Telomerase is also needed in DNA replication to fully reproduce the telomeres when cells divide. Free radicals are highly reactive chemicals produced in normal metabolism. Then there's programmed cell death theories that propose the aging process being genetically programmed. Now, despite many variations, no single theory is sufficient to explain aging. There are also 3 important structural changes in the neuron. Neurofibrillity tangles are the spiral-shaped masses that are formed when fibers that compose the axon become twisted together. There are dendritic changes, which are complicated changes in the dendrites, and there are also neurotic plaques, which are structural changes in the brain produced when damaged and dying neurons collect around a core protein. Each of these has important consequences for functioning because each reduces the effectiveness with which neurons transmit information. The level of neurotransmitters, those chemicals that we use in neuron communication, decline with age as well. Structural neuroimaging provides highly detailed images of anatomical features in the brain. In other words, we use CT and MRI scans. Functional neuroimaging provides an indication of brain activity, but not high anatomical detail like SPECT scans, fMRIs, PET scans, and NIRSIs. There's also the risk of cardiovascular disease, and it tends to increase with age as people are affected by lifestyle. Now, normal changes in the cardiovascular system include a buildup of fat deposits in the heart and the arteries, arteriosclerosis, which is the calcification and blockages in the arteries. Those things decrease the amount of blood that the heart can pump and also helps then decline the heart muscle tissue and stiffens the arteries. Stroke and cerebral vascular accidents can cause significant cognitive impairment that depends on the location of the brain damage. Transient ischemic attacks, or TIAs, involve an interruption of blood flow to the brain and are often early warning signs of potential stroke. Numerous small cerebral vascular accidents can result in a disease termed vascular dementia. Now, there are normative changes in the respiratory system as people age, and they're hard to identify due to the lifetime effects of pollution. The most common form of incapacitating respiratory disease among older adults is chronic obstructive pulmonary disease. It's also known as COPD. Now, COPD can be extremely debilitating. It also results often in depression, anxiety, and the need to be continually connected to oxygen. Emphysema is the most common form of COPD. Growing older brings with it several normative changes in sensory abilities, including vision, hearing, and taste. Presbyopia, which is difficulty in seeing close objects clearly, necessitates longer arms or corrective lenses and is caused by structural changes involving the lens. Some people actually experience diseases caused by abnormal structural changes. Opaque spots on the eyeball, called cataracts, may develop in the lens of the eye. Fluid may build up in the eye and not drain properly, which causes very high pressure, which results in what we know as glaucoma. A second major family of changes in vision results from changes in the retina. With increasing age, age-related macular degeneration increases the destruction of receptors in the eye. Diabetes is accompanied by accelerated aging of the arteries, with blindness being one of the more serious side effects. Now, age-related changes in hearing can also affect people's ability to function in their own environments. The cumulative effect of noise and normative age-related changes create the most common age-related hearing problems. They're called presbycusis, which is the reduced sensitivity to high-pitched tones. Now, the sensitivity or the sense of taste remains largely intact even in older adults, as do touch, temperature, and pain sensitivity. Substantial declines in the ability to smell will start to occur after the age of 70. Changes in balance make older people increasingly likely to fall, and the sensory changes people experience have important implications for their everyday lives as well. For those who have chronic disease, it can also create a number of lifestyle health issues. Diabetes mellitus occurs when the pancreas produces insufficient amounts of insulin. Type 1 diabetes usually develops earlier in life and requires the use of that insulin. Type 2 diabetes typically develops in adulthood and is often effectively managed through diet. Cancer risk increases sharply as people age. The risk of getting cancer increases significantly. Early detection of cancer, even in older adults, is essential to maximizing the odds of survival. Some of the other problems associated with sleep happen to be due to other health problems as well. Sleep concerns can disrupt a person's circadian rhythm or the sleep and wake cycle. Nutritionally, most older adults do not need vitamin or mineral supplements as long as they eat well-balanced diets. Metabolism changes across the lifespan due mainly to differences in or how much energy the body needs. Immigrants tend to show poorer health than U.S.-born people with the same ethnic background. So with health concerns, that also leads to the potential for cognitive difficulties as people age, including, first of all, those related to information processing. Age differences in divided attention tasks depend on the level of difficulty. On easy tasks, there are no differences, but on harder tasks, younger adults always do better. Older adults' speed of processing, or how quickly and efficiently the early steps in information processes are completed, is slower than younger adults. The amount of slowing tends to be lessened if older adults have practice or expertise on a particular task. Psychomotor slowing is a universal phenomenon. It's also a good predictor of cognitive performance. The prediction is best when the task requires very little effort. When the task requires more effort and is more difficult, then working memory is a better predictor of performance. Now, divided attention concerns how well people perform multiple tasks simultaneously. Older workers are just as able to multitask, but they perform each task a bit more slowly than younger workers, and with training, older adults can improve. Working memory involves the processes and structures involved in holding information in the mind and simultaneously using it to solve a problem, to make a decision, perform some function, or learn some new information. Working memory is an umbrella term that's used for many similar short-term holding computational processes that relate to a wide range of cognitive skills and knowledge domains. Working memory has a relatively small capacity and deals with information that is being used right at the moment. Working memory also tends to decline as people age. Of course, as people age, memory becomes a concern, and poor memory is often viewed as part of the inevitable aspects of aging. The study of memory aging generally focuses on two types of memory. We have explicit memory, which is the deliberate and conscious remembering of information that's learned and remembered at a specific time, which includes episodic memory and semantic memory. Episodic memory is the general class of memory having to do with the conscious recollection of information from a specific time or event, while semantic memory is the general class of memory concerning the remembering of meaning related to words and concepts that's not tied to a specific time frame or an event. Implicit memory is the unconscious remembering of information learned at some earlier time. In laboratory memory tasks requiring free recall, older adults almost always do worse than do younger adults. A second area of memory research concerns autobiographical memory, which is memory for events that occurred during one's particular lifetime. For younger and older adults, vivid memories experienced between ages 10 and 30 are reported more often than those occurring after the age of 30. Differentiating memory changes associated with aging from memory changes due to the disease, which should be done through comprehensive evaluations. Memory training can be accomplished in a number of ways. For example, a useful framework is to combine explicit implicit memory distinctions with external and internal types of memory aids. External aids are memory aids that rely on environmental resources such as notebooks or calendars. Internal aids are memory aids that rely on mental processes such as imagery. Creativity is assumed to be a function of younger people, whereas wisdom is assumed to be the province for older individuals. Creative output increases through one's 30s and tends to peak in the early 40s before declining. Older adults are still creative, but they produce fewer creative ideas than when they were younger. Neuroimaging research using the Hunter Imagination Questionnaire have shown imagination to be related to a wide array of brain volume in areas such as the hippocampus, frontal lobe, and other brain regions. Wisdom is also more related to being an expert in living rather than with age per se. Baltz and his colleagues describe 4 characteristics of wisdom and include important or difficult matters of life and the human condition, superior knowledge or judgment and advice, knowledge with extraordinary scope, depth, and balance applicable to specific situations, and when used, it's well intended and combines mind and virtue or character. There really is no association between age and wisdom. Cultural matters are also influential when it comes to understanding wisdom. Younger and middle-aged Japanese adults use more wisdom-related reasoning strategies than middle-aged Americans. 3 specific factors help a person become wise: general personal conditions, the specific expertise conditions, as well as facilitative life contexts. We've got cognitive concerns, physical issues, and of course, no discussion of aging can be complete without dealing with mental health and certain potentials for intervention. There are a number of age-related differences in the symptoms dealing with depression as we examine diagnostic depression. For example, the rate of depression declines from young adulthood into old age for healthy people, while Chinese adults show higher rates of depression. Depression in later life is usually diagnosed on the basis of 2 clusters of symptoms, which include feelings and physical changes. The key symptom of depression is persistent sadness or feeling down, which is termed dysphoria. Older adults are more likely than younger people to appear apathetic and expressionless, confine themselves to bed, neglect themselves, and make derogatory statements about themselves. Physical changes, including the loss of appetite, sleep difficulty, and breathing problems, also reflect the second cluster of symptoms associated with depression. The major causes of depression include imbalances in neurotransmitters and psychosocial issues, such as loss and internal belief systems. Internal belief systems are what one tells oneself about why certain things are happening and are emphasized as the cause of depression. People who are depressed tend to believe that they are personally responsible for all the bad things that happen to them, that things are unlikely to get better, and that their whole life is a shambles. Depression can be treated with medication and through psychotherapy, such as behavioral therapy, which holds that depressed people experience too few rewards or reinforcements from their environment, or cognitive therapy, which is based on the idea that maladaptive beliefs or cognitions about oneself are responsible for one's depression. Along with depression, there's the potential for anxiety. Anxiety disorders include problems such as feelings of severe anxiety for no apparent reason, phobias with regard to specific things or places, and obsessive compulsive disorders in which thoughts or actions are repeatedly performed. Anxiety disorders are particularly common in older adults due to the loss of health, relocation status, isolation, fear of losing independence, and many other concerns. Anxiety disorders can be effectively treated with either medication or psychotherapy. With these particular mental health concerns, also we need to include the ideas related to dementia. And it's a family of diseases that causes severe behavioral and cognitive impairment. For example, Alzheimer's disease is the most common form of irreversible dementia. The key symptoms of Alzheimer's disease include gradual declines in memory, learning, attention, and judgment, confusion as to time and place, difficulties in communicating and finding the right words. Other challenges related to Alzheimer's include decline in personal hygiene and self-care skills, as well as inappropriate social behavior and personality changes. Now, those symptoms usually worsen gradually, with rates varying considerably across individuals. In its advanced stages, Alzheimer's disease often causes incontinence, which is loss of bladder or bowel control, and loss of total mobility in some cases. Now, a definitive diagnosis of Alzheimer's disease can only be made following a brain autopsy. Diagnosis of probable Alzheimer's disease can be made after a thorough process through which other potential causes are eliminated. Now, a great deal of attention has been given to research on beta amyloids. The beta amyloid cascade hypothesis refers to the process by which beta amyloid deposits create neuritic plaques that in turn lead to neurofibrillary tangles, which then cause neuronal death and, when this occurs severely enough, what we know as Alzheimer's disease. Now, although Alzheimer's disease is incurable, various therapeutic interventions can be made to improve the quality of the victim's life. One behavioral intervention ranges from large calendars to interventions based on EIEIO approaches. Parkinson's disease is known primarily for its characteristic motor symptoms, which include very slow walking, called the Parkinson shuffle, difficulty getting into and out of chairs, and a slow hand tremor, but it can develop into a form of dementia. Parkinson's disease is caused by insufficient levels of dopamine and can be effectively managed with a drug, of course, named L-Dopa. Symptoms of Parkinson's are usually treated effectively with medication and surgical interventions using a device called a neurostimulator. Chronic traumatic encephalopathy is a form of dementia that's caused by repeated head trauma, such as concussions, and of course, will influence people's aging as it relates to cognitive capacity. I've often heard that growing old isn't for sissies, and as I enter my late 50s and begin to move closer towards 60, I can attest to that fact. I'm not saying that I'm not healthy or that I have significant difficulties, but I can tell you that aging is not for sissies at all. Hopefully, you've come to better understand at least some of the aspects related to older age and adults as they continue to age. It actually brings to a close the number of issues related to our study of lifespan development across the lifespan. Hopefully, it leads to a better understanding of how people and human creatures in general function, and will provide you with some of the information you need as you continue your education.